Down fracture. Talking jaws.
Yes.
See, I can't hear anything, Wasson.
All right.
Neither can I.
All right,
I
if it
can
sounds
see
good
it
to you,
jamming,
that's what
though.
matters. So
Did you hear it at all?
Yeah, I heard fucking down fracture, I think, at one point. I'm not.
yeah, I wasn't clear there was not a cuss word either. It was either there or not.
All right, whatever. All right, so we attempted to play our new absolutely amazing intro music. Maybe that didn't work, but so we are again on our Down Fractured podcast, Talking Jaws. So per usual, this is Dr. Michael Wasson here with my usual co-host, Dr. Sam Bobek. Sam, how's it going?
It's great.
Just great.
Bad beauty, December. So
Yep. And so now we also have a special guest, Dr. Zach Brown from Kansas City, right, Zach?
Yeah, Kansas City, Missouri.
Tell us a little bit about your practice, facial surgery group, I think it's called. What do you guys do up there?
Yeah, I got out of residency in 2020, and we converted it from a teeth and titanium, like very efficient teeth and titanium mill to full scope. So we take trauma contracts at 3 essentially level 1 trauma centers, and now we do orthognathic, TMJ. We started a cleft team out of a semi-pediatric hospital, which is its own conversation. And then we all kind of share in the orthognathic pool, but I'm kind of the TMJ surgeon, and I went to the residency in San Antonio. It's where I learned to do TMJ under Dan Perez. And yeah, it's been a great 4 years, man. I mean, we do a lot of orthognathic and TMJ surgery. There's not a lot of private practice people doing it, it seems. So still kind of an untapped market. So we're kind of it's been good for us being kind of the first to want to do it.
Nice.
Good to have you, Zach.
What'd you say?
It's good to have Zach here. Appreciate it.
It is good to have Zach here. Well, so Zach, what's the topic that you wanted to speak to us about today? I think it's one that I could use to listen to some myself.
Yeah, so like when you're doing all these hospital surgeries, efficiency, especially in private practice, efficiency in the OR is like super important, So we're just going to talk about, especially for everybody getting out of residency or wanting to start back into orthognathic or trauma, you don't want to spend all day, 4 hours, 5 hours, just waiting around so you can do like a simple effort. It's going to take you 2-3 hours max if you're having a bad day, So, I think I don't know what everyone's residency times are really. I mean, I think every program is a little different, but with custom plates and screws and custom TMJ replacements, if you can get in and out of a double jaw in 4 hours, it's a great day, So doing that is kind of the goal. So that's kind of what I want to talk about.
Yeah, that sounds good. Yeah, I'm the poster boy of who needs to hear this because my situation just keeps changing and I can't make it stable. And before we hit record, you were mentioning some things about staff and, having everyone on the same page and other things. You want to walk us through some of what you do that you feel like makes you more efficient?
Well, I mean, I don't know if I'm any more efficient, but I feel like, when you think about what you had in residency, when you're learning how to do this, you have like a team. You have the same OR staff that you scrub techs, everybody that knows what you're doing. You have the same implant reps or, medical device reps that know exactly what you need and what parts and trays to pull out. You have, residents to scud out work too, which, we don't have, which is why we become a little inefficient because we don't have those tools. And then, the hospital has the trays. They know exactly what you need. So really like kind of disassembling what your residency experience was like and rebuilding it in your private practice OR setting. It's exactly what, I kind of been able to do for the most part, but it takes a team to help you. So,
I mean, my experience with efficiency is it's definitely an important aspect of this, right? We can keep costs down. Patients do better if they spend less time in the OR. Just general provider well-being's better. But man, I've had it all over the place. I mean, I went to a residency where, depending on the team and I was, I guess, the resident observing these things. I mean, we could spend a ton of time, like 8 hours, two jaw,
Oh, yeah.
that crazy, like get down, patient spent a couple nights in the hospital type thing. I went to a fellowship where they had the whole team teed up, and I thought when leaving fellowship, it was going to be easy to finish off a two jaw in 2 hours. Like, I didn't
Right.
know how you could spend any more time on it than that. And then you get out on your own and you realize, holy smokes, like, I think I was appreciative of all those things that existed, but I didn't really understand how they were making everything work. And
Right.
when you're on your own, you just show up to a hospital and you're like, hey, I got my pick list, and why don't you just use this stuff and just do everything that I'm saying? That may not actually result in efficiency. And so part of it's kind of accepting that it could be inefficient. Like for me, that was
Okay.
kind of like a big first step. So before kind of getting into like the ways to make it more efficient, it's just like, it's not saying anything bad about you that it's taking a bit more time, because I think we all accept the culture that if you spend more time doing a surgery than another surgeon doing a surgery, people see that as there's something wrong with the person that's taking longer. But that's not necessarily the case, right? Like, Zach, when you went to the hospital out of residency that you're at now, were there other senior guys doing the cases, or girls, or Trevor?
In my private practice?
No, at the hospital that you do the cases at now.
No.
Okay,
But
so
they
you
had
got
trays
into it.
from a decade before.
Okay.
And then
Crucial
my
first step.
yeah, right. The old school. They're still labeled from the guys before me, which is actually kind of cool knowing who used to do it,
Yeah,
and how they
totally.
used to do it. But yeah, nobody really was doing it. And we had our own tray, which was actually a big help, as we had our own orthognathic tray that John Tanner, the kind of predecessor of my program, my private practice, he had a orthognathic tray, and he used to do 50 to 100 a year back in the heyday, the 90s, 2000s, when insurance paid something. But nowadays, I don't think a lot of people going out. I mean, you might still have an orthognathic tray, maybe rusty wherever you go. But I agree with you, though. I think efficiency doesn't necessarily mean fast. I mean, it's nice to be fast, but surgery takes as long as it takes, right? You do a good job, and that's all that matters. So I agree with you on that. Like, there's no time stamp that's like, yeah, this is like what you have to have, but making it so that it's not stressful, and you know what steps, and you have a team around you. I think this is the biggest part. So, yeah, I would say, do you guys have your own trays?
Oh man, you're going to give me some stress here. I do not. I just struggle where I am now. Part of my struggle is that they often will open, and I kid you not, 4 or 5 trays just to get me what I need. And I've spoken to them about consolidating things or getting own trays. Sometimes you make some progress, sometimes you don't. I feel like the people I deal with are very reasonable and nice, but it's just, sometimes I'm using needle drivers that I feel are like from ortho or GI, or, I'm just, what kind of surgical set doesn't just have like DeBakey's and reasonable like Langenbeck retractors? And so like I'm constantly fighting that battle of this case, we open this 3 out of the 5, and the next case they open a different set of 3 out of 5. And so we're scrambling every which case. So to answer your question, no. And that's why I was kind of saying I'm currently the epitome of inefficiency, because I've had to move hospitals multiple times. I finally had an assistant who was accredited with me, but that took 10 months at the
Yeah.
first hospital I was at. And by the time I had done a couple months of cases with that person, they leave. And now I got to wait, another 10 months. So then I started working at a different hospital with the residents, which is helpful in that they can do some of the work, but they're still learning how I do things, and the scrub techs and everyone are still learning how I do things, because it's drastically different than what the other
Yeah.
people do. And the other issue I would say is that we all know, but maybe it's important to put it out there, and you both have said it, but having your team, and it's the same team every time, and they know what they're doing. And then that's where I may have a different resident or residents with me each time. Like I don't have a dedicated so and so's on rotation with me, so I have them for 4 months. So maybe the first week, 2, 3, we put in a little effort, and then the next 3.5 months we kind of coast. So I am the epitome of inefficiency currently, because if I don't get there early and help them set up, it doesn't get done. Even if we update, quote unquote, my card every single time, it's just maddening to me, and so frustrating to me, because Sam and I come from similar experiences in that the people we kind of followed or tagged onto in Seattle originally were very efficient. If their double jaws went more than 2 hours, that was a weird, bad day for them. And like you're saying, that expectation then falls onto you, and it's nice to have their infrastructure in place sometimes. But then if you do things differently or need different things, like you're saying, I always felt that pressure, Sam, of like, people who trained me did this in 2 hours and it took me 4.5.
Yeah. And you think, well,
That's
what's wrong
real.
with me, right? Like, because
Right.
you internalize that. And I think it is a hard transition. I know it turns people off in terms of doing hospital cases, in that you go from your training program where things were smooth and it just seemed to work out, and then that's not the case. And then increasingly in your practice, because you're in private practice, it's smooth, right? Like it's just things work out well because you're doing it a lot. And so trying to figure that out at a situation where you may not do as much, because I think, Zach, you were saying in terms of volume, right? Like if all you're doing is jaw surgery, then it's a bit easier to develop a team. But if you have less of that, it could be harder, right?
No, it's definitely tough. I mean, I only do one OR day a week. I do about 30 major cases. Like we're talking like a double jaw, joint replacement. Like I don't consider a MITEC or an arthroscopy like a really major case, but essentially like I do about 30 major cases, just myself. And the practice adds onto that. But it's like, that's not a lot. You're talking every other week. And so they're not going to give you, I have a dedicated room block for the practice, but we don't have the same scrub techs every time. We don't have the same, circulators, anesthesiologists are different every time. So they don't know. Half the time I get asked for a double jaw if they're going to do a nasal intubation. You know what I mean? It's like, well, yeah, we kind of need that for this kind of surgery. It's like, but where you train, everything's well oiled. So it does make you really question why. Well, it doesn't make you question, it makes you kind of reason why you wouldn't necessarily want to do it right out of residency, because there's so many hurdles. And then if you didn't actually have a tray set up or something, or you weren't confident out of residency, it's tough, man, to get that started in a hospital.
I mean, it's tough to do a case with just you and a scrub tech. I mean,
Not fun.
Not fun. And Sam,
No.
you have a, what are your, I forget what you call it, but you have a few things that from an anesthesia perspective that immediately let you know that it's going to be a bad day. I think one of them is asking for an A-line.
Yeah, you need an A-line. What kind of tube do you need? I think those two tend to be the biggest ones. I think the A-line question is getting me. I guess Foley is also the question. But I mean, I think what we're getting at is, I want people doing surgery, right? I think we all want people doing cases and being successful at it. And part of that is kind of recalibrating what's efficient, right? Like you shouldn't be trying to do a double jaw in 2 hours if it's you and a scrub tech. Like don't focus on that, right? Like, I mean, let's talk about efficiency in a different way rather than, this hypothetical 1 hour double jaw that apparently exists online. Even though I think we all know the reality. But I think it's important, but there's other things that are important. And, moving an 8 hour case to 6 hours. Sorry, my dog's hanging out with me. She starts barking if I say 8 hour double jaw.
Yeah.
With good reason.
But if you take a 6 hour case and move it to 5.5 or 5, that sort of thing, and just trend it in the right direction. I think talking about ways we could, maybe give some people advice in that way, I think is probably helpful, right?
I mean, I think
go ahead.
I was gonna say for sure. I mean, essentially the thing that takes the stress out of me. So like, how long you take to do the surgery itself, you can only do so much with the tray setup you have, with the help you have. But the pre-surgical work to get everything kind of set up so that you don't have to stress the day of. I mean, God, when you have to look for, you know, a double safe osteotome so you don't rip the nasal floor to shreds on a 3-piece Lafort, you know, I mean, it's not fun because you're just looking through trays and trays, and you just have to kind of make do sometimes with whatever you can get. But I mean, I think all of it boils down, though, a lot of it to just preoperative before the surgery, having a surgic like a really decent you know, rep for your company that you use, whether it's KLS, whether it's Synthes, because realistically, that's a person for me that kind of runs the back end. They get the tray set up, they make sure that they have the IMF screws, or you know, they have the wires that I want. And I kind of demand it. I don't demand, I'm not mean, but you know, I kind of demand it of them like, hey, like this is gonna be a great day for us. We're gonna go get lunch together and hang out if we get this case done fast enough, because you're on the ball while I'm trying to work up the patient and do all these things. So I kind of scud them out like a resident.
Yeah, I mean, I think a rep that's helping you out is super helpful. Like you don't really appreciate it until you work with someone that isn't that helpful as a rep, because they do all the behind the scenes work. But I think in terms of doing most of the legwork on efficiency before you start operating, I think that's probably the most fruitful area.
Oh yeah.
Because you know, you're thinking about hour 2 or 3 when you're in the case and you're trying to speed up, but that's not how you speed up. You set it up ahead of time. I
Oh
think
yeah.
that's important. And so you were mentioning instruments. Wasson, why don't you have a kit, man? You gotta have a kit.
Man, you don't even want to know my struggles. They will just make you depressed.
Can I tell you a story about a kit at a hospital that I don't go to much anymore, but I still
Sure.
I can go to. There's a place where they wouldn't purchase instruments because they didn't have money in the budget, but they would allow me to purchase instruments. So kit
Wow.
ethics for me was about 25K. And then they would hold it there. And if they lost any of the instruments, they would replace it. If I brought my kit in with me, they can't be responsible for losing anything. And so it was like these hospital policies and hospital budgets. Um, that's that whole discussion led to me not wanting to operate there much, as you would imagine. But like those sort of things are real, right? You go to a hospital, it's not like, hey, we'd love to pay 25K to a surgeon we haven't met before who's done 3 cases here. You know what I mean?
Doesn't happen. Took me 3 years to get a scope, like a
Yeah, I mean,
not
that's pretty good
expensive
time,
case.
actually. I felt like, yeah, good work on you to get it that early. Is it that sort of thing, Wasson?
Yeah, I mean it's a lot of different things, you know, because now I'm mostly at the university hospital, and so they have other priorities in some ways, other surgeons who are there doing trauma and other things. But it's a struggle every time to where I kind of always wondering, like, shouldn't we all be motivated to get a tray or two? Because if you open 3, 4, 5 trays, well, what if a trauma case comes in and the other surgeon needs one of those cases? Like, that's not going to work. And I worry about it selfishly. Like, if that happens a time or two, they're going to stop letting me do this. But, you know, to me, I'm always just mentioning that to them of like, why are we opening, you know, 5 trays? That's not efficient. That's not cost efficient. It's not time efficient. You know, and again, just to me, I'm just mind blown frequently of like, how do you have like an OMFS tray that doesn't have a single osteotome in it? It doesn't have a mallet. It doesn't have a DeBakey. It doesn't have normal, you know, what we would consider normal, you know, drivers. It doesn't have bite blocks. It doesn't, I mean, like the things that you would just think would be in any OMFS tray, like these are the first things you throw in every tray, are frequently not in multiple trays. And so it's just maddening.
Yeah,
So,
no, but at the same time, you could understand their viewpoint that
of course,
if one person walks in and they just want to change the generic kit, they can't say yes to that because there's other people that would be using it. And you know,
I mean, those people would want it too. I mean,
exactly. So I mean, it's I mean, being able to bring your own kit of instruments and that sort of thing, I think is a good way to go if it can be pulled off. But um, you know what? I've generally found to be useful, even though I honestly have Andrew do this. Zach, I have a PA that I work with, and
Nice.
we've been together maybe like 7 years now. But I observe her do this for the scrub tech person, in that she gets all the instruments laid out. Like, we'll show up early, and it's really just to set everything up for them.
Yeah.
And to get rid of the instruments that we're not going to use. Because there's things you aren't going to use in those 4 kits that you're talking about opening.
Oh man,
yeah.
it's a mess.
Because shit, and you lose so much time spending 10 seconds looking for one instrument. There's too
Yep.
many steps. Like, you will lose so much
10,
time.
10
You
seconds
spend
would be
10 more
refreshing.
seconds.
Yeah. 10 seconds would be refreshing, man. I mean, that's exactly it, because the more trays you open, not only is that inefficient, but now you have more to dig through each time you can't find something. And then the wrong instrument gets put in the wrong tray for the next time. So it's just increasingly, frustrating. And yeah, so I guess let me take this to a different turn, and maybe where we make this more practical and useful for anyone of the 7 people who might actually listen to this. So if we were, going to take this, let's just throw it out there that this is a double jaw orthognathic case, nothing crazy, no joints. I guess let's help the listeners maybe paint a picture of what we think would be an efficient, like what are the ways to make it efficient? Like if they wanted input as to how to make it efficient, I think anything you can do ahead of time, you do ahead of time. If that's, even start your op notes, getting there early, setting up instruments, having a team. I guess walk us through that, and we'll start with you, Zach, since you're our guest. Like, what are some things, even starting from just the beginning? Maybe it's treatment planning, maybe it's custom hardware. Like, walk us through, start to finish, what would make a case efficient from your standpoint?
I mean, I use custom plates and screws, which is super helpful. I mean, I feel like just for me, from a time standpoint, and I only really do it in the Ford. I don't do it in the BSSO. Now, it does increase your costs in the hospital, so you have to be careful with that. I got, one of my hospitals stopped letting me do patient-specific implants because there was, too much cost associated. But that's one big thing that I always do, because it's going to save me probably 30 minutes to an hour of having to tell the scrub tech what screw you need to have, telling the scrub tech, to irrigate here, bend all the plates, pick them out, hold the jaw. So patient-specific implants for me saves a lot of time on the Lefort, especially with a 3-piece. And that's just pre-planning. And then realistically, I go in early and I do very similar to what your PA does, man. I go in and I scrub beforehand. I'll consent the patient and I'll scrub beforehand, and I'll just grab everything I need for the whole case. I'll put it on the Mayo, and it's like way too busy. I take everything else and I put it in one of their trays, which really, you ought to just start putting them all in a tray and say it's a Wasson tray.
I wish.
I mean, they wouldn't even know. I mean, they probably wouldn't even know, man.
Who knows? Who knows?
And then I just have like all my Lefort down fracture instruments in a pile, and all my SSO instruments in a pile, and I have all my number 9, my wires, everything. And it's all set up. So I grab everything myself. And then I have the scrub tech on the other side of me, retracting and suctioning. And every once in a while, most of the time I'm pretty fun. I just let them play whatever music they want, and we just, shoot the shit for, like 3 hours, 5 hours, whatever. And I get somebody else to scrub with me if I can. Then I've got somebody at the head. I got someone, and I just grab all the instruments myself. It's way faster, and I put them back where they're supposed to be, rather than them putting them all wherever, and then they have to look for them. And it's just that's it. I do the Sonopet every time. Don't have to bind a recip saw. Sonopet's in every hospital. Neurosurgery, if they have neurosurgery, they're going to have a Sonopet. I just tell them the exact blade, and I tell them to buy 10 of them for me. And I tell them that neurosurgery is going to use it too, even if they don't, who cares? You know what I mean? But, because recip saws, that was a big problem for me, finding recip saws. So they couldn't find them. It was awful. So,
yeah, I mean, like,
those are my things. That's my workflow.
That sounds like a necessary way to be efficient, but just that thought drives me crazy, because, like, what is the point of a surgical card? Like, they harp on it to me. They're like, "Oh, we need to update your card, and can you help us do this?" And then I'll do it, and it doesn't change anything. Like, if you're not going to look at the card, let's just throw it out. Like, just burn it. Like, there are people who could use the heat. Let's burn it. And that's what's just so infuriating to me, is because I feel like I'm working on both ends. I'm putting in the work to update the card, and then I have to still get there early and put in the work to make sure things are set up correctly.
Right.
Like, it's
I
working.
would give up on the card, man. I think you
Yeah.
just got to do it because it's like one of the things people do. But it's, there's no, I haven't experienced any, I haven't observed enforcement of like accurately pulling for the card. Like they're trying their best. They're probably understaffed. It's like,
Yeah.
I get it. And so,
Well, and you're gonna get it once. One person's gonna do it, right? That one person scrubbing in the back or doing sterilization is gonna do it for a while, and then they're gonna leave, and it won't matter again.
Yeah.
because the people updating your card also got me too. I used to focus on the cards, and now I've just given up on it. Because I mean, there'll be people who are new to it, right? There'll be a nurse in the room that's new, and they're like, "Hey, I want to learn this." Like they mean well, and they're like, "Hey, I noticed that you're using 4.0 chromic instead of the 3.0 that's on your card. Let me update it." And it's like, well, no, I still need 3.0, And then the next case, the cards change. Anyway, I think there's, I don't know, I when it comes to efficiency for me, I think there's things like that you are in control of, and then there's things that just the system is going to be inefficient for orthognathic surgery unless you're in a great system, right? And I mean, you stick with it, you'll create a great system. But I mean, when you're starting, you're not going to be in that unless you joined a practice where that exists. And
Right.
so you just have to work with that situation. Like Zach was saying, I mean, working with the scrub tech across the way and you're pulling off a sagittal osteotomy is technically hard. Like that is a technically hard thing to do.
Mhm.
So it becomes a game of what are you using your hands to do, and do you really need to do the things? Because we've talked about with surgery of the sagittal osteotomy, like the ideal fixation or managing the nerve or interference management or wisdom teeth, right? Like I think those sort of decisions ahead of time probably influence efficiency at the what we're talking about. Because I mean, while I think strongly you should take out wisdom teeth at the time of jaw surgery, if it's going to be you and a scrub tech and it's going to be a hard situation, getting those teeth out ahead of time probably makes your life a little easier, right? Like, I don't like custom hardware at all. Not, I don't hate it, but I think its role is minimal. But I think there's a role for it in speeding you up if you're spending a lot of time bending plates, right? So I think,
Yeah.
knowing your situation, being honest and kind of saying like, hey,
All right.
I can control
Well,
some stuff, but not everything.
Honestly, doing a Lefort first custom plate means that I don't have to worry about my assistants getting any of the X-rays right, because it's solely on upper one and has no relation to anything else, right? And then in the end, as long as my maxilla is in the right spot, splintless, I always get a splint as backup. I check it, and it's accurate. 99% of the time, it's pretty close. I usually don't buzz all the occlusal interferences right off the bat. But then when I go to put my BSSO, my problem is you have to have an assistant holding the jaw when they're in MMF, holding them in Lefort, and you're trying to plate it. They don't want to irrigate because ortho doesn't irrigate their drills, right? So for me, it's like a huge worry that I'm not having to hold them in at the vertical that I want if you're doing Lefort first. If you're doing mandible first, which I was raised either way, right? And Perez is the Wolford disciple, right? So it's very much mandible first all the time, and that's what I do with my joints. But essentially, who's holding the proximal segment? Who's making sure that it's passive? It's just really kind of a difficult thing to do and juggle when you have a different scrub tech or assistant every single time.
It's like a whole different surgery. It really
Oh, yeah.
is. I mean, because like efficiency, as we're talking about, getting out of fellowship and having this idea, like I was set to a certain efficiency level. I tried to do the operation as if I had two other seasoned people around me helping me, when that just wasn't the case. And
Yeah.
so if there's residents that listen to this, I would try to learn to do cases on your own. Like I had a lot of positives in fellowship, but one of the negatives, I've given them the feedback, is that it should be taught as a different operation, because there's different ways to hold the proximal segment if it's just you and the scrub tech, and there's different fixation strategies and different approaches, man. Like, the
How
SR,
do you
like,
fixate your SSO?
I use plate. I use a plate and screws. I honestly do hybrid. I do a plate and then a single screw on top a lot of times. Wasson hates that, but I think it's awesome.
Not a single screw, man. Just
Single
put
screw's the
two there.
best.
You
In
got the
addition to a
plate.
plate, there's a plate already there.
Yeah, there's a plate already there.
Nonsense.
He just likes poking holes in manuals. Anyway,
What do you do, Wasson?
Kind of the same. I usually do 2 screws and a plate.
Yeah, I'm that way. That's Ellis used to do it that way.
But
Pros
what I'm
did
getting
too.
at in terms
But
of
yeah, go ahead.
being frustrated with efficiency, that can slow you down when you're like, why can't I hold the proximal segment? It should be seen as a different thing, like,
Well, you got to learn how to position your assistants. Like
Absolutely.
you got to
Yeah.
teach them where to retract and how to retract. You got to literally, when you're asking for an instrument, you also need to be asking for your scrub text instrument. Okay, you're going to need this and this next, and literally feed them what they need to do while you're doing your own surgery. That's why I like to grab my own instruments, to be honest, because it's like, okay, grab this and this for yourself. I'm going to grab the number 9 because you don't know what that is, and that's, you have to, it's the surgery. Once you get the surgery in residency, you need to learn how to direct your residents that's helping you, because that's what's going to make you fast, is, directing your assistants.
Absolutely. Yeah, I think that's something I struggled with, probably still do. And I always try to relay that to residents when I work with them, is like, hey, just because I'm the attending, you're holding the saw. So you need to tell me, I can't see through your eyes. You need to tell me, and they're always hesitant, because, oh, I'm the resident, this is the faculty. Like, I don't tell them what to do. Like, you have the instruments, you tell me what I need to do to help you. And I think you're exactly right. I think we come out and as residents, you're so, you learn what you've learned, but you're not good at directing other people how to help you. I still struggle with that. You think, oh, I've done this operation hundreds of times. Everyone here knows what to do. And the reality is, this might be the first and only time this person never sees this. And that's all of the struggle. I would throw out some other ideas, because I know Sam, you got to go soon, probably.
Yeah, but keep throwing them out. I got a little time.
I would throw out some ideas of, some stuff is obvious and we were mostly focused on the OR, but, have, your op report templates, have templates either where you copy and paste them. Most dictating software have templates you can use now. I would say do all that stuff ahead of time, spend the time doing that. If you can have an assistant or a PA or a nurse practitioner who goes with you to every case, who can share that burden, having an assistant who is there with you every time, I think is huge. Getting your instruments and everything set up ahead of time, I think is huge. Anesthesia, I would even say positioning of the patient. Can we do some reverse T? Can we give them transexamic acid? Can we control the blood pressure with not just blasting them with, SIVO? All of these things I think make a difference. Sometimes they're overlooked. All of the, oh man, it's going to skip my mind. What is the protocol? You give them meds ahead of time, all that stuff. I'll forget what it's called right now because I'm out of it.
Like an order set?
What's that? But no, but I mean, like, oh gosh, I can't think of it. Basically, I give every patient
anesthesia.
I give every patient Tylenol, Lyrica, scope patch ahead of time. All of these things that have been shown to decrease postoperative pain, get them out of the hospital faster, decrease opioids.
Sure.
You know what I'm talking about. What is that called?
I think your suggestion that you can't remember has influenced my recollection of it as well. I know what you're talking about, but it's not preemptive analgesia. It's like the whole suite of care in terms of optimization of the care. But
though, you bring up a good point though. It's giving them all those meds in your pre-op appointment and all that stuff too. Your post-op meds.
Yep.
Gosh, that's a huge problem for me. Is you in the hospital, given all those meds, and having to type them all in and put your fingerprint or whatever the system is that's completely different in every hospital to give them meds. Giving them all in that H&P appointment and scheduling their follow-up a week out is a huge efficiency thing with me. I mean, it changed my life because you'd have to do it all in the hospital. And the nurses are like, "Oh, when are they going to follow up with you? Do they have
you
their
can't do that at
post-op
the
meds?"
hospital.
Yeah.
You had me worried there, Zach. I thought you were giving prescriptions at the hospital. I was like, Jesus, that sounds
No.
terrible.
Oh yeah.
No, that's great.
Efficiencies. I
I
do it
mean,
all myself.
No, the ERAS protocol. That's what I'm thinking of.
I got it.
But yeah, I mean, I think those things help. Yeah, I do the same thing. Everyone gets their post-op instructions and their meds at their H&P appointment, and then we tell the nursing staff, hey, they have everything. It's just so bizarre. Like every hospital like requires that the patient be given something. Like so, like if you do jaw surgery, they're given some random sheet that has like instructions on it. It has nothing to do with what you want them to have. It's kind of weird. I think those things can help. ERAS protocol, if you can have an assistant there all the time, set up ahead of time. I think expectations, as you were mentioning, Sam, are huge. Like, because that's where I get frustrated. I'd get out of residency and I'm like, I'm used to doing this case in 2 hours, a double jaw in 2 hours, and we might do 3 of them today. And then you get out and that doesn't happen. And that makes you upset, frantic, stressed, and so then you're exhausted, and then it just compounds the problem. Just set reasonable expectations.
I want to put 2 other bugs just for ideas that I think are helpful. They're helpful for me. For sure, I think it was one that Zach talked about, which is the teamwork business, like setting up music that makes your staff happy, like, create an atmosphere of levity rather than stress. That's just going to make everyone work better. The second one has to do with surgeon break. I'm gonna just put a plug. I don't know, Wasson. We were talking about breaks.
Yeah, we've talked about it. And we also, spitballed the idea of having one of these be about operator well-being.
Yeah, totally.
And so maybe this is a plug for that.
Yeah, but I mean,
talk about mythical stuff.
You don't even hear about fucking breaks, right? Like, I mean, as a resident, it's like, you want to take a break? What's wrong with you? Like, you're a surgeon, just keep working. Everyone in the OR is taking breaks except for you and the patient, right? And if you're in a case and it's taken longer than you think it would, it helps me a lot to take 5 minutes or to just change gloves or get out and get a little snack or something. That will set you up, because you can slow yourself down. I think when it comes to efficiency, you can fuss about things, you can do things that you're part of the problem yourself. And so getting away and taking a few moments will help you out a lot.
I definitely do that with Team JR if there's a LaForte. If I do the Team JR, I always, you got to scrub out and do crap anyways, but I always take a break, go get something to eat, drink.
But if you knew your case was going to be a 4-hour 2-jaw, what's wrong with taking a break when you turn the corner, right? You finish up the mandible. It's like, hey, I'm going to go get just water. Like,
there's nothing wrong with it. Unless you have cases to follow and other things, but there are other variables that come into play.
Give the scrub tech to catch up. They could get their Mayo stand all sorted out.
Well, that's presuming that they know what you want. And so I often do take a break, but that break is more to, let's get the first JAWS instruments off the Mayo and put the new JAWS instrument onto the Mayo, kind of as Zach was describing, where he set, he has his LaForte and his SSO instruments. But I mean, I guess that's kind of a pause, but I usually don't scrub out for a 2-jaw. I mean, there's absolutely nothing wrong with it. It probably would make me feel better. I mean, even just taking that freaking headlight off your head for a little while, would probably be beneficial for overall wellness and keeping you fresh.
If I go back in time and give myself advice 8 years ago or 10 years ago, it'd be that. Just take a break. Like, it's okay. Just take a few minutes. Now,
there's no ego anymore. It's not. It's no ego, man. It's just take care of yourself. I agree.
Yeah, completely. Well, sweet. I think we'll wrap it up there. Well, thanks, Zach, for being a guest. Again, that's Zach. Dr. Zach
awesome,
Brown from Facial Surgery Group in Kansas City. So anyone listening to this, feel free to send them patients if they can't get to Arizona or Seattle.
Yeah.
Instead. And yeah, good to chat with you, Zach, and we'll be in touch.
Yeah, absolutely. We'll see you
around.
around.
Nice meeting you. Take care.
All right. See ya.